So I invite Dr. Jagdishwar about the robotic esophagectomy and rectal laryngeal nodal dissection. I invite him.
Yeah, good morning to all. I have given the topic of recurrent laryngeal node dissection. These are ports. One is the right side is the monopolar. This port we have designed for especially the supraesophageal dissection. The one on the right side is the bipolar and the camera and the stent port. So two ports of 5 mm and 8 mm are used. This is scapula. Initially we tried below the scapula, but we felt the opposite side recurrent laryngeal lymph nodes. The left side was very difficult. So we designed these ports. And this is a system we use always prone and sometimes semi-prone too, but most of the time it's prone position. Our steps are very standardized, 10 steps. We start in the infraesophageal vein with the monopolar and bipolar. We have the opportunity to have worked with all 4 generations of the robo. These are the pulmonary vessels. These planes are very important. The anatomy for the postgraduates is entirely different on the right side and the left side. Over the subclavian vessel, this is the nerve that goes in the prone position, and this is the left side. We always clear bilateral recurrent laryngeal lymph nodes, aorta pulmonary window as part of the staging procedure. This is in the patient is in the prone position. This is esophagus vein, aorta, esophagus, and we always use ICG also for thoracic duct detection so that we avoid any complications. This is an anatomy in the prone position that was hand drawn by me. And this is a trachea. We never use a double lumen tube. That's very important in recurrent laryngeal node dissection. We should never use because the tracheal is a post-tracheal membrane. If you use a double lumen tube, it engorges the tracheal membrane, and chances of injuring the membrane is very high. So we use a single lumen tube. The pressure is around 8 millimeters mercury. So that's how we go on to the other side over the post-tracheal membrane, and we use only 2 instruments. The stent roll practically nil. Even the supraesophageal, infraesophageal, the steps are very standardized. We start anteriorly, then posteriorly. We use esophagus vein clipping because aorta pulmonary window and the left recurrent laryngeal lymph node dissection is easier with the clipping of the esophagus vein. You can see so beautifully with the robo, the 3-dimensional. This is actually 2D view, and in fact it's 3D view in our this thing. So that's how the recurrent laryngeal nerve courses across. It's a straight, and sometimes sympathetic nerve branches also, cardiac branches also will be there. And this is how it dips in aorta pulmonary window, the right side. And we divide it into dorsal and ventral side when we do the left side nodal dissection. The esophagus is refracted. We never catch the esophagus. We should use the hump of the instrument to retract it. So especially the oncological principle, so that we don't tear or do any. This is the case of lower 1/3 esophagus, post-chemo RT. And once we clear the lower down, this is how the view comes, the left bronchus, carina, right bronchus. And because of the end of wrist, we can go over easily without any retraction need. This is how you can see without double lumen. This is a single lumen tube. And because the ability of the end of wrist of the scissor, we can bend it and go to the other side. There are 2-3 points. One is vagus nerve we can identify on the right side. On the left side, the lateral border of the tracheal membrane should be seen. And the esophagus can be retracted towards our side. That's a aorta pulmonary node there. And that's how you go slowly, steadily, in a stepwise manner. We should never hurry up, use minimal cautery there. And we should not enter the hiatus totally or to the next side totally. Once we clear the right bronchial and left bronchial, then we go on to the right RLN and the left RLN. You can see we have reflected the esophagus up and doing the dissection on the other side. So that's how you do the dorsal and ventral type. This is the right side. We identify the vagus nerve and then go up towards the recurrent laryngeal nerve. This is how the RLN curves over the subclavian vessel, and we clear the disease after the right bronchial nodes. If we cannot identify RLN directly, we can identify the vagus nerve and go on. And all these lymph nodes should always be bagged. We should never pull them out through the ports, maintaining the oncological principle. So this is how it curves around the subclavian. The pictorial diagram for identification. So you can see so beautifully the 3D view. That's how the RLN goes there. And we can go all up to the lower part of the neck. And most of the time bipolar is cautery is used more often, and cautery is at very, very minimal setting we use, very, very minimal setting, almost less than 15 if it is a Valley Lab. And that's all the nodes are cleared there. This is, the right side is a little bit easy. Initially we used to use, when 11 years back we started, we were a little using the cautery more, and we realized there is some amount of paresis, and patient was not able to cough out and was needing more ICU care. So from that time we have changed it. The cautery setting is very minimal, and most of the time we use the bipolar, and this is how we always bag the nodes. And subcarinal node dissection is done in the middle, and then we go on to the left bronchial and the left recurrent laryngeal nerve nodes. That's the opposite side are nodes. And you can see here, this is aorta pulmonary window here, and the lymph nodes. As you can see, the aorta pulmonary nodes there, and the nerve is straight down. Nerve is straight down. We should never use cautery there. The plane should look very clean, and cautery setting, if at all we use, should be very minimal, and it should be away from the nerve. We should not go close to the nerve. Try to do a blunt dissection most of the time. If there is a oozing, we can always put a gauze piece and wait. We should not bother about oozing in this area. So that's how we do the dissection and identify all the lymph nodes and bag them and take them out. So my topic was RLN. I just PPT. No, start from beginning. The topic, the session is actually a very nice topic, disruptive technology. Lot of disruptive technologies are coming. In fact, in Boston, they have started robots where the sensors are kept in the cranium, and surgeon is able to operate some instruments. So that's a disruptive technology that's going to come in the future. And bots are going to be small, not like big ones which we are using. There will be nanobots which will go inside. So I think IASGCON has chosen an appropriate topic. And these are the lymph nodes which are very important. The extent of mediastinal lymphadenectomy, overall survival, still data is not there, but definitely disease-free survival, and disease-free survival is better compared to the not doing it. And many times we have seen 6 to 40% of them do have lymph nodes. And we always believe in removing the recurrent laryngeal lymph nodes. The only problem with the robot is its cost. There's a monopoly of one company. Hopefully, made in India robo will come in the future. Definitely, a lot of advantages is there. 3-dimensional. The surgeon's tremors are cancelled in robo. So even a 70, 80-year-old gentleman can operate with ease. And 3-dimensional view, ICG inculcated in the system, and no tremors is a big advantage, especially the endowrist is a big advantage in the robot. We always do esophagectomy by robotic means, and it's doable. The technique is standardized. And this is a paper we published of 162 cases of robotic esophagectomy quite long back, almost 2019. And we are quite happy with doing the robotic procedure, but we hope to reach rural, teach robotic. We visit AIMS, SGPJ, and so many centers. Our dream is to make a made in India robo. Hopefully that comes in the future. Thank you so much for giving me this opportunity.
Thank you for the excellent presentation. Any questions or comments from the audience? We'll keep it brief, please.
Brilliant video as always, Dr. Goud. So you've been kind of mentoring us also. 2 years back we started with your help, and then we moved forward. A few questions which keep on recurring again and again when you do this particular dissection, and all options are open in literature, how to actually take out those lymph nodes. First question is it always en bloc or is it separate? So the answer to that in your video is, I think, separate, is it?
No, en bloc is very, very difficult, sir.
So, okay.
Because especially the RLN, left RLN and aorta pulmonary are quite separate.
Yeah, the left one.
And oncologically, it doesn't matter as long as you take them and bag them in a plastic pouch. It doesn't matter, sir.
Yeah, I understand that. I'm just trying to put it out
Yes,
there,
sir.
because
Yes.
these questions are unaddressed and not
Yes,
really clear out there.
True.
The second question really is that how high do you go on the left side?
We on the left side,
Yeah.
up to the, just into the entry into the neck. Actually, we can go quite inside of the neck. Sometimes we see the esophagus is motile mobilized in the cervical also, but we should not cross the cervical entry point so that the gas doesn't leak too much and the hiatus side.
Okay. The last question really is, which was asked by my colleague there, was that if you have to prevent neuropraxia or neuroparesis in the post-op period, what are the pointers you will give in dissection, whether it's open or robot, doesn't make a difference, the same thing. What are the pointers you will give that these are things not to be done?
Yeah, instruments, we should never catch the nerve, sir. Instruments, we never catch the nerve. Use the hump of the instrument to retract it. Second thing, no, you don't use a cautery. In case you do require a cautery, use at a very low setting. Varila, we use almost less than 10, it's just to buzz it and 1 or 2 sparks. We should never do that. We can always use harmonic, but it's quite expensive. It costs 24,000 more. So number 1 is don't catch the nerve. Number 2 is don't use minimal cautery. If at all, use bipolar. And if there is a oozing, put a gauze, wait, it will stop, sir.
Do you loop the nerve with a loop?
No, sir.
Never?
No, sir. Never do traction, never stretch the nerve. Okay. We have burnt our hands initial cases. Okay. Patient was not able to cough out and sometimes they needed a lot of ICU care and all.
Okay. Aortopulmonary window, how safe is that node dissection? All patients, sometimes these patients have nodes which are very adherent and it's very dangerous to go there.
Yes, sir. The left recurrent laryngeal nerve, aortopulmonary window, only the recurrent laryngeal nerve nodes is the toughest thing in a robotic esophagectomy, especially the aortopulmonary window. But as a GI surgeon, as an oncologist, we always need to standardize our technique, so we always sample it or remove it and send it. It is definitely difficult. With over a period of time, maybe 20-25 cases, it can be done, sir.
Thank you so much.
Dr. Goud, if the node comes positive post-operative.
Pardon, sir?
If the node comes positive post-operative,
yes, sir.
You give adjuvant radiotherapy or some other things?
Yeah, we have a multidisciplinary tumor board. We submit it to that. We have a standard protocol pre-op. Nowadays, actually, neoadjuvant chemotherapy is given. Yes. RT is being avoided. And then based on the adenos, squamous, number of nodes, and we submit it to the MDT. Yeah, MDT, and very rarely we get a direct surgery cases.
Thank you.
Okay. Thank you so much, ISGO, for giving me this opportunity.